So welcome, and thank you for this opportunity to have a chance to talk with you. I was earlier this week in the U.S. I actually flew home this morning, and while in the U.S., I took my first Uber ride. So I downloaded the app, and I ordered a car using the app, and I was very proud of myself. That I had been able to do that. And then I started thinking that I had actually used the phone to order a taxi. And when you sort of say it like that, it doesn't sort of sound that strange, right? People have been using the phone to order taxis for the last 100 years. But you still can't argue that Uber and other innovations like that wouldn't have changed how we live and really revolutionized how we and many other people communicate and operate in this world. And it's not the technology as such, but it's how it's changed the system, how it's disrupted what used to be very traditional professions, such as driving taxis. Does this work? Yeah. The Human Genome Project, and when it was announced its conclusion some 16 years ago, was also intended to revolutionize healthcare. And this is the announcement of that. I was at that time working at the National Human Genome Research Institute in the US with the person there in the picture with the glasses and the mustache. That's Francis Collins. He currently leads the NIH in the US. The bald-headed guy is Craig Venter, who actually ended up sequencing the human genome first as a private entity. And then Bill Clinton seems to have something else on his mind in the picture. Now, after that June 26th, I actually joined BCG pretty much a couple of months afterwards. And the intention was that to use all of that genetic knowledge to help pharmaceutical companies, biotech companies into developing new drugs and really sort of drive genomic technology into mainstream practice. That hasn't really happened. And it's really only now that we are starting to see personalized medicine, use of genomics really hit the mainstream. And one of the reasons is the technology, but the other is that there was not really a understanding of genetic heterogeneity. And to understand what that means, let's take a step back, not 16 years ago, but more than 100 years ago. And to a person whom I think some of you know, or at least have heard of, Wilhelm Johansen, a Dane, has an institute named after him somewhere here in Copenhagen, apparently. He was actually the person who came up with the word gene and the definition for it. And then, more importantly, while working at Carlsberg, developing probably the best beer in the world, he also came up with the concept of genotype and phenotype. So he was looking at different types of plants, and he noticed that even when he was analyzing the same plant and the offspring of that same plant, where the genes, the genetic makeup would be completely identical, they would still look different. And he called that sort of phenotypic variation. Now, if you look at healthcare, there's just huge variation in healthcare. This chart here shows differences in healthcare spending, healthcare outcomes, and how people are treated in hospitals for how long of a time in different OECD countries. So each bar here is one country, and it's evaluated against the mean. Now this is comparing different countries, but it's actually the same if we would compare it within a country, within a hospital department. That variation exists, and it's huge. It can be even 20-fold. And that variation masks all of that genetic knowledge that we talked about. I mean, those differences are fairly minute. The risks of, let's say, having a breast cancer susceptibility gene that confers, compared to a 20-fold difference in outcomes. And why that variability exists is that there's not good measures of what is good clinical practice. What is a good doctor? What do they do? Do people get better? How quickly? And it came with a need to define clinical outcomes. So actually, if you have a hip operation that you walk afterwards, for some illnesses it's easier. So if you have cancer, you get cured, you don't have the cancer anymore, and so on. And it actually was a business person who came up with at least part of the solution. This is Michael Porter. He's a professor at Harvard University Business School. And in 2006, he wrote a book about healthcare. And he came up with the definition of value-based healthcare. And value defined as outcomes divided by cost. And that's value. And those outcomes are outcomes that matter to patients. So it's not just a clinical result. Let's say HB1AC, which is measured in diabetes, but it's actually the fact that the patient does not get the complications of diabetes, or whatever a good outcome measure for that is. And what he also said is that to improve healthcare, one needs to look at that variability, measure those outcomes, analyze the variation, identify what good hospitals, good doctors are doing, change those behaviors, do feedback and learning, and get that virtuous cycle ongoing. Now, this sounds like great theory, right? It's coming from a business school professor, right? But does it work in practice? And this is where the Boston Consulting Group comes in, and specifically, this is where a partner colleague of mine called Stefan Larsson from Stockholm comes in. And Stefan had been for a long time fascinated by patient registries that exist in Sweden. They exist in Denmark, for that matter, as well, where doctors have for decades now collected information on patients, their treatment, and what was the outcome of that treatment. Did they get better or not? And how quickly? And then in Sweden, this information has been collected, and in 2007 it was actually made public. And this is now comparing different hospitals in Sweden. It's sort of a composite quality index. And the lines you see there are sort of separating all hospitals, which is the green line. And then the blue line is the bottom half of the hospitals, those who are doing, or were in the lower 50% deciles in the sample. And after the outcomes were made public, everyone improved, but it was those worst performing hospitals that improved significantly better. And now this, of course, is doctors and scientists are smart people. If you show them the facts, if you show them the data, they will improve. They want to find out what are they doing, or what could they be doing better? What are the others doing that they could do as well? And that's what happened. There were no guidelines. There were no top-down measures. The government saying that now you have to improve. You need to do this. The doctors, nurses, other healthcare professionals in those hospitals, they found out for themselves. They changed by themselves, and they improved. Now this is Sweden, and a lot of our colleagues in the Boston Consulting Group were like, well, yes, we know Sweden, and Sweden is a perfect place, and all things work in Sweden, so will this work in the real world? And Stefan then started looking into this with some of our other colleagues. And he looked at different systems. He looked at not only Sweden, but the US, Germany, and Spain as examples here. And he basically found out that, yes, if you measure outcomes, you get better quality by either measuring the absence of complications, reducing mortality, improving patient satisfaction or survival. But that was not the only thing that they found out. They actually found out that when you improve the outcomes, you don't need to spend more. You actually save money by improving those outcomes. Because people are not coming back to the hospital to get treatment again. They don't have complications. They're actually diagnosed, they're treated, and they go back to living fruitful lives. And now if you think about what's happening in the healthcare sector, here in Denmark, in other parts of Europe, the US, we're talking about that we can't afford our healthcare system. It costs too much. Actually, if we were focusing on the right things, we were measuring the outcomes, we were taking out the waste in our system, and just doing those things that have proven to improve outcomes, we could definitely afford our healthcare system and even more. And that's what convinced Stefan, and that's what convinced us in the rest of us partners in BCG to do something about this. And the one thing that was missing in applying value-based healthcare, one of the main things missing in applying value-based healthcare, were standard definitions of patient outcomes. So let's take cardiovascular disease. So what is an outcome? What is a good patient outcome? Is it the blood pressure being at a certain level, the absence of arrhythmia? What constitutes Alzheimer's disease? What's a good outcome measure for Alzheimer's disease? These didn't really exist. There were some ideas of it, but it wasn't standardized. So Stefan came together with Michael Porter from Harvard and then Martin Ingmar from the Karolinska Institute, and they developed and put together a new institute. It's a non-profit organization called the International Consortium for Health Outcomes Measurement, whose mission it is to help and enable doctors, physicians, to define these outcome measures. So they take leading physicians from all over the world, let's say in the field of prostate cancer, they get them to work together and come up with what is the minimal set of outcome measures that are needed to be able to define, has a patient improved after treatment or not? And it's a handful of metrics that are needed. This was founded now in 2012, and every year it has, there's also been sort of a yearly symposium. I was at that symposium earlier this week, where more than 800 people from around the world gathered to talk about outcomes, talk about value-based healthcare. Among the speakers were the Minister of Health for Portugal, the Minister of Health for Belgium, leading insurance companies, medtech companies, pharma companies. There were also 20 people from Denmark, basically from all the regions, from the Ministry of Finance, the Ministry of Health. And it was great to sort of hear how this has taken off, and people are not talking about the concept anymore. They're actually talking about the results of applying this concept. And currently we have more than 20 sets of outcome measures defined for basically most of the common diseases in the world, and it's still ongoing. Every year there's sort of 4 to 8 more sets being defined. So now, with these outcome sets, we have it all. So what we can now do is we can use our genetic understanding to define and segment patient groups. We can identify those women who have a susceptibility to breast cancer. We can identify people who have a genetic predisposition to Alzheimer's disease, schizophrenia. And now we can also measure the results of that treatment, see what works, what doesn't work, evaluate that, and then improve and change. And we can start actually making informed choices about where to treat people. Is it in their home? Is it in primary care? Is it a specialist? Or which type of hospital? And which treatments where? Making sure that actually those treatments are not only the most cost-effective, but actually that they improve patient outcomes. And that's why now, sort of 16 years after the announcement of that Human Genome Project, I'm actually much more confident that we are on the verge of a revolution in healthcare. And it's a very exciting time to be in the industry. I'm sort of envious that you have a lot of more time to live in this world than I do. And you can sort of embrace it all now. And I think it's just sort of an exciting place and time to be. Thank you.